that we can do. I have no financial or proprietary interest in this product or techniques here in this presentation. Now we know the definition, and we know that there are two really additional things that have come up in 2007 following the DEWS workshop, which is hyperosmolarity and inflammation of the ocular surface. And these are the two concepts that I'm going to build upon, other than discussing the broad outlines of the medical management of dry eye. Now, in this new terminology, or the new definition, the dysfunctional tear syndrome encompasses decreased tear volume and tear film abnormalities. The classification is based on the severity of the symptoms and signs, and a treatment algorithm is then based on the severity and the symptoms and signs. It's recognized that most cases of dysfunctional tear syndrome have an underlying inflammation, especially in the chronic phases, which may not necessarily be clinically evident. And it is confirmed that patients with a dry eye might move between these severity levels and become worse if they are left untreated. The treatment options, largely, the mainstay will always remain lubrication of the ocular surface. And ophthalmic solutions containing water-soluble polymers will remain, again, the mainstay. And these may be in the form of artificial tears, ointments, or gels, which may be either preserved or non-preserved based on the requirement. This is the treatment chart which has been laid down by the DEWS workshop, wherein they ascribed 4 levels of severity to this condition, levels 1, 2, 3, and 4, with differences in the symptoms and the signs, and based on the corneal staining and other signs as well, and the treatment options that were there for each of these levels of disease, and I'll go into these details in just a moment. In level 1, patient education, basically talking about the environmental modifications and the look at systemic medications as well as other systemic conditions that may actually be leading to dryness, and the use of preserved tears, since we are hoping that we'll be able to get away with less than 4 times a day dosing, and allergy control. Now, allergies very often coexist with dry eye and are often missed, and that is something that one must look at in these patients. If there is no improvement, then we move to level 2 treatments, which is we go to unpreserved tears, add nighttime support in the form of gels and ointments, as well as nutritional support with a question mark, which really means looking at omega-3 and things like that. And of course, the addition of cyclosporin, the use of topical steroids in short bursts, and secretagogues. And if there is no further improvement, looking at tetracyclines and punctal plugs to control the inflammation of the before of course putting punctal plugs, we would like to control the inflammation, and looking at systemic anti-inflammatory therapy and even surgical methodologies, which is going to be discussed by the subsequent speakers. Supportive therapy would mean reducing evaporative losses by using shields and special goggles, creating reservoirs of tears using various forms of contact lenses, and humidification of the environment by humidifiers and vaporizers. Temporary methods like what is being shown here, which is plugging, can be done, wherein an lacrimal occlusion, which may be either temporary using any absorbable material, or it may be permanent using either a permanent punctal plug or either a laser cautery or punctoplasty. But this can be done to try and build on what is being used as part of the medical management. In the evaluation of the underlying disease, blepharitis is extremely important, especially in our parts of the world. We find meibomianitis or posterior blepharitis and anterior blepharitis to be very, very commonly coexisting. And of course, a look for systemic autoimmune disease and getting the rheumatologist to come into the picture along with the use of systemic steroids and immunosuppressives. If there is lid margin disease, the DTS algorithm that I showed you was for pure dysfunctional tear syndrome without lid margin disease. But when there is lid margin disease, the use of hygiene or cleansing of the lid margins, the use of antibiotics, using various shampoos or even diluted betadine to scrub the eyelashes, fomentations, lid massages, the use of local steroids and oral tetracycline as well. And if there is disorder of the tear distribution, Dr. Raju very nicely showed conjunctival chalasis and the treatment, which may be either correction, replacement, or a reconstruction of these lid conditions. This would be a part of the management. And to go back to this mild, moderate, severe, again, the slides are shown to just give you a broad overview of what needs to be done in these patients. There are some new concepts that have come up. One is the lacrimal functional unit. The other is the ocular surface system and the vicious cycle. And the Dew's model also showed us two new concepts. One was hyperosmolarity and the other was ocular inflammation. This is the vicious cycle. It's a complex series of things that happen which leads to tear instability and hyperosmolarity, which are part of the core mechanisms. And of course there's inflammation, which affects the acinar lacrimal gland. And this is the core mechanism where tear hyperosmolarity and instability produced by either evaporative loss or low tear production can lead to a cycle of continuous damage. And the hyperosmolarity and instability can initiate, amplify, and potentially change the character of the dry eye over time. Now let me take you back many, many years to some fundamental concepts of osmosis. Now osmosis is simply the movement of water across a semi-permeable membrane and is largely determined by the concentration of solutes on either side. This membrane is semi-permeable. It doesn't allow solutes to pass through, but it does allow the egress and ingress of water. And when the concentration of the solutes on either side is the same, then this is considered to be what we call an isotonic state, which is the ideal state. But in dry eye, there is loss of the tear film, there is a loss of water here, and what that does is it makes this area hyperosmolar or hypertonic, and that causes the water to get sucked out from the cells, thereby dehydrating the cells of the ocular surface. These cells in the hypertonic environment lose water and they shrink as they become continuously dehydrated. And we know that these dehydrated cells don't function well. In the compromised tear cells, these cells are out of balance and the ocular surface shows signs of damage, which we can pick up clinically with various forms of methodologies, including surface staining. So the response to hypertonicity in a normal cell, when exposed to this hypertonic environment, there's water loss, it becomes dehydrated and shrinks. And then what it does is it does a regulatory volume increase. And how does it do it? By bringing in salt, which means sodium and potassium. And though the cell volume gets restored, the hypernatremia causes a decrease in cell function, stress activation, and eventually cell damage and death. Now there is another alternative mechanism that the cell can employ, which is to bring in compatible solutes. And this regulatory volume increase will restore the cell volume without actually affecting the metabolism of that cell. Numerous tissues and organs in the body which experience hypertonicity, like the kidney, the heart, and the brain, protect themselves by either synthesizing or having the mechanism to import these compatible solutes. And this process of being able to do this import is called osmoprotection, where the cell function is then maintained without further damage. Unfortunately, the corneal epithelium does not have this capacity or ability to import compatible solutes. So it tends to become dehydrated and lose osmotic balance. So if there is a mechanism that can protect the surface as well as restore the osmotic balance below the surface, that would prove to be more useful in this hyperosmolar state. And the methodology being used is to incorporate these compatible solutes, which, like I said earlier, are small non-ionic molecules within the eye drops to help protect the corneal surface from within. And L-carnitine, erythritol are used as compatible solutes along with essential electrolytes in these formulations, which are going to be osmoprotectant to the corneal surface, thereby lubricating the surface by any of the polymers like carboxymethyl cellulose and glycerine in this formulation, and using L-carnitine and erythritol to restore the osmotic balance beneath the surface. The other concept that has got introduced is the concept of inflammation of the ocular surface. And for that, cyclosporin is now extensively being used. We know that cyclosporin is a T-cell inhibitor. It actually inhibits the interleukin IL-2, which is one of the factors which causes the T-cells to multiply and become activated, which is fundamental to the inflammatory cycle of the ocular surface. So these migrating T cells which get activated and then secrete cytokines and damage the acinar cells get suppressed, and the cyclosporin induces an apoptosis and normalizes the inflammation within the acinar gland. What else is happening other than osmoprotection and anti-inflammatories is tear stimulants, oral pilocarpine, bromhexine, the retinoids, petrolatum-based ointments, artificial tears inserts are being looked at. Autologous serum for the patients who are more severely involved, hormone drops, and I'm hoping that in the next couple of years we should have something clinically available. There's already fairly well into the trial phase of these drops. So to summarize, dry eye signs and symptoms are extremely variable. They can go up and down in severity. The response to the therapy is similarly very variable. No one treatment fits all. And although algorithms are useful to initiate management, treatments have to be tailor-made for each individual based on the experience and the clinical response. Thank you so much.